Okay, guys, good morning, everyone. Uh, Today we will continue with our book club on the fundamentals of diagnostic radiology. Today is the first chapter of the chest imaging with your colleague, Dr. Mahabad. She can start this point. Okay.
Good morning. Our subject today is methods of examination and normal anatomy, while the radiographic findings of chest disease will be covered by my colleague next week, inshallah. The decision for which image procedure to perform depends on many factors, with the most important one being the availability of various modalities and the type of information required. Conventional radiographs of the chest still constitute about 25 to 35% of volume of any general radiology department. Our main topics are imaging modalities and normal chest anatomy. Regarding the imaging modalities, we have conventional chest radiography, of which the posterior, anterior, and lateral chest radiographs are the mainstays of thoracic imaging. Chest X-ray should be performed as the initial imaging study in all patients with thoracic diseases. Proper radiographic techniques on a PA view involves assessment of four basic features, which are the penetration, rotation, inspiration, and motion. Proper penetration can be assessed by visualizing the faint intervertebral discs and the branching vessels through the cardiac and diaphragmatic shadow, while rotation can be assessed by the interposition of a midline drawn between the medial ends of the clavicle that should be superimposed on a posterior line of the spinous process. If these two lines are superimposed, this means they have a proper position and no rotation is present. Regarding inspiration, we usually look at the right hemidiaphragm that should be both at the level of the 10th rib posteriorly or 6th rib anteriorly. And for the motion, the cardiac and the diaphragmatic edges should be sharply seen, while the patient is doing a breath hold, standstill during the examination. Within the conventional chest radiography, we have the portable radiography, digital computed radiography, of which dual energy subtraction, and chest fluoroscopy. For the portable radiography, portable anterior-posterior view are obtained when patients can't be safely mobilized. Its advantage, it helps monitor a patient's cardiopulmonary status and assess the position of various monitoring and life-supporting tubes, lines, and catheters, and detect the complications related to the use of these devices. The portable radiography has limits, which is its maximum kV potential requires longer exposure to penetrate cardiomediastinal structures, which results in greater motion artifact. And since the patient is critically ill, so there is a great degree of rotation. And the X-ray beam cannot be directed perpendicular to the chest, and that's why it results in a kyphotic or lordotic radiographs. Because of the short focus length, it's about 40 inches, here. This will cause magnification of the intrathoracic structures. So we cannot properly interpret the cardiac size, and which is normal. The cardiopulmonary ratio is 50%, it will increase to 57%, so the cardiac size will be increased for 15 to 20%. And it is difficult to assess the venous hypertension and pneumothorax because the patient is lying supine, causing the diaphragm pushing the lower lobe vessels. There is a new device, which is called the inclinometer, has been developed to accurately recall the position of bedridden patients from supine to completely upright. It is added to the unit of the X-ray, and Thus, we can assess the hypertension, pleural effusion, and pneumothorax. Regarding the digital computed radiography, its advantage is superior contrast resolution and availability of the image on any computer monitor through a picture archiving communication system. Contrast levels and windows can be adjusted to enhance visualization of various regions in the chest or compensate partly for faulty exposures. We have a subtype called dual energy subtraction, utilizes low energy 60 kilovolt and high energy 120 kilovolt to produce selective bone and soft tissue images respectively. Its advantage improves visualization of lung nodules, calcification, chest wall and pleural lesions, hilar masses, and localization of indwelling tube lines and catheters. We said that the main view is the posterior anterior and the lateral view. We have some special techniques like the lateral decubitus radiograph. This detects small effusions of the decubitus side or small pneumothorax in the contralateral side. As little as 5 ml of fluid, 15 ml of air can be demonstrated. Expiratory radiographs can detect focal or diffuse air trapping and eases detection of a small pneumothorax. It's obtained at residual volume, end of maximum expiration. Another special technique is called apical lordotic view. It provides unimpeded view of the apices. Usually, in a PA view, the apices of the lung are obscured by the clavicles and the first costochondral junctions. That's why we must angulate the X-ray beam cephalocaudally, so it moves the bone superiorly and allows visualization of the apices. It enhances visualization of the middle lobe atelectasis by placing the inferiorly displaced minor fissure in tangent with the X-ray beam and by increasing the anteroposterior thickness of the atelectatic middle lobe. Passing to chest fluoroscopy, it's nowadays used mainly to assess chest dynamics on patients with suspected diaphragmatic paralysis. CT and high-resolution CT scan. Talking about the modes, we have stop, acquire, and go, such as for high-resolution CT in a helical mode, whereby acquisitions occurs while patients translate through the gantry. The second mode is step and shoot mode, data acquired in contiguous 12 to 16 centimeters long stacks of images triggered to one phase of the ECG tracing. This markedly reduced radiation dose and maximizes longitudinal coverage and is therefore most useful for coronary and aortic CT angiography. Multi-detector scanners with 256, 320 detectors now allow for full chest coverage with collimation of as narrow as 1 millimeter in approximately 3 to 5 seconds. Scans without contrast are performed for evaluation or follow-up of parenchymal diseases. Contrast material is administered for mediastinal masses, cancer staging, systemic or pulmonary arterial evaluation, and for cardiac studies. High-resolution CT, thin section CT technique involves incremental thin collimated scans, 1 to 1.5 millimeters obtained at evenly spaced intervals through the thorax for the evaluation of diffuse bronchial or parenchymal lung disease. Expiratory high-resolution CT is useful for detection of air trapping. Volume of data in helical CT is acquired with a collimation thickness of 0.5 to 1 millimeter, to 10 millimeters. Regarding the advantages of CT, its superior contrast resolution, allowing the differentiation of calcium, soft tissue, and fat within the lung nodules or mediastinal structures. Cross-sectional display eliminates the superimposition of structures and allows visualization of the parenchymal nodules as small as 2 millimeter. Regarding the indications for CT is evaluation of an abnormality identified on conventional radiographs, staging of lung cancer, detection of occult pulmonary metastasis, detection of mediastinal nodes, distinction of empyema from lung abscess. Contrast-enhanced CT can usually distinguish a peripheral lung abscess from loculated empyema. Detection of central pulmonary embolism, detection and evaluation of aortic diseases, aneurysm, dissection, intramural hematoma, aortitis, and trauma. High-resolution CT is indicated for solitary pulmonary nodules. Detection of lung disease in a patient with pulmonary symptoms or abnormal pulmonary function studies and a normal or equivocal chest film. Evaluation of diffusely abnormal chest film. A baseline for evaluation of patients with chronic diffuse infiltrative lung disease. And to determine approach, type, and location of biopsy.
Just keep in mind, for HRCT, high resolution CT, first it is done by having thin cut, 1 millimeter, 0.5 millimeter, then leaving 10 millimeters in another thin cut, then leaving 10 millimeters in another thin cut to reduce radiation exposure. This will indicate that we might lose focal abnormalities in the 10 millimeter that we scale. That's why it's indicated only for diffuse lung disease, like emphysema, interstitial fibrosis, bronchiectasis, things like that. It's reconstructed using high resolution bone algorithm. It's used bone algorithm. So why we don't do it for everyone with high resolution bone algorithm? Because it's high resolution. We can do it for every case. Why we don't do it? Because high resolution means more details and more noise. So we'll have higher noise level first. Second, if you do it in every patient, you need to do it continuously. And if you do it continuously, we'll have a very large radiation dose. So it's indicated only for diffuse parenchymal lung disease, and it is without contrast. Always without contrast.
Thank you. Passing to the magnetic resonance, morphologic studies usually require only spin echo, T1 and T2 sequences in the axial plane. Coronal and sagittal planes are used in selected cases. Mass evaluation might benefit from fat-suppressed sequences. Angiographic acquisitions are most often performed with GRE, gradient or gradual record echo, volumetric acquisition. Cardiac sequences benefit from cardiac-gated balanced, steady-state free precession techniques. Respiratory motion is minimized by performing rapid single breath hold acquisition or by using respiratory compensation techniques. Its advantage is superior contrast resolution between tumor and fat, ability to characterize tissue on the basis of T1, T2 relaxation times, ability to scan in direct sagittal and coronal planes, ability to obtain images along the long axis of the aorta, and the advent of SYN-MR technique have made MR the primary modality for the imaging of most congenital and acquired thoracic vascular disorders. Direct coronal scans are of benefit in imaging regions that lie within the axial plane and therefore difficult to depict on CT. For this reason, superior sulcus tumors, subcarinal, orthopulmonary window lesions, and certain hilar masses are better depicted by MR than CT. MR is superior to CT in the diagnosis of chest wall or mediastinal invasions, and the characterization of tissue by their T1, T2 relaxation time allows for the diagnosis of fluid-filled cysts, hemorrhage, and hematoma formation. The ability to distinguish tumor from fibrosis based on T1, T2 relaxation time has proven particularly useful in the follow-up of patients irradiated for Hodgkin's disease. The major disadvantage is MR is currently unable to distinguish benign masses from the malignant masses or lymph, and scanning have limited spatial resolution, the inability to detect calcium, and the difficulty in imaging the pulmonary parenchyma. MR is also more time-consuming and expensive than CT. Indications for MR of the thorax is evaluation of aortic disease, dissection aneurysm, intramural hematoma or tites. Assessment of superior sulcus tumor, evaluation of mediastinal, vascular and chest wall invasion of lung cancer, staging of lung cancer patients unable to receive intravenous iodinated contrast, and evaluation of posterior mediastinal masses. We have PET scan. Fluorodeoxyglucose is an imaging modality based on the metabolic activity of neoplastic and inflammatory tissues, and therefore can be considered complementary to the anatomic information provided by chest radiography and CT. It's used for evaluation of patients with malignancy, particularly bronchogenic carcinoma, and of thoracic PET for the evaluation of solitary pulmonary nodules. Sonography, transthoracic sonography, is now commonly used for the detection, characterization, and sampling of pleural, peripheral parenchymal, and mediastinal lesions. In emergency room and critical care settings, thoracic sonography is used to detect pneumothorax and to guide central venous catheterization. We have ventilation perfusion lung scanning. It's used almost exclusively for the diagnosis of pulmonary embolism. Gallium-67 scanning of the chest is used in the detection of pulmonary infection, pneumoscarini, pneumonia in a patient with a normal radiograph, or inflammation, example disease activity in idiopathic pulmonary fibrosis, and the evaluation of suspected sarcoidosis. We have diagnostic arteriography, transthoracic needle biopsy, percutaneous catheter drainage of intrathoracic air or fluid collections. It is performed by imaging guided placement of small bore multi-hole catheters used for the treatment of empyema, pneumothorax, malignant pleural effusion, and other intrathoracic fluid collections. Passing to the normal lung anatomy. Doctor, if you allow me, I will just explain on the images. So, normal lung anatomy, starting with the trachea. The trachea is a hollow cylinder. It's a hollow cylinder composed from C-shaped rings of cartilage, C-shaped cartilaginous rings, which is completed posteriorly by the posterior tracheal membrane. The lateral wall of the distal trachea is indented by the transverse portion of the aortic arch. The trachea measures about 12 centimeters long in adult, and its coronal diameter being 25 millimeter in male, 21 millimeter in female. Sometimes there will be narrowing of the coronal diameter of the trachea, causing the coronal to the sagittal ratio, which is normally 0.6 to 1 millimeter, being less. Since once it is less than 0.6 millimeter, it is called a Saber sheath trachea.
0.6, not millimeter, just
0.6 ratio. Yes, sorry. And on posterior anterior chest radiograph, the right lateral border of the trachea can be traced down, since it will interface with the right upper lobe of the lung, producing the right paratracheal strip. This right paratracheal strip should measure no more than 4 millimeter. Once it is thickened, this indicates a disease in that region, like, for example, medial tracing pleural effusion. Posteriorly, the trachea extends from the cricoid cartilage superiorly to the bifurcation of the main bronchi. We have on the lateral view the anterior wall of the trachea can be seen, and the posterior wall is also demarcated. The trachea bifurcates to the right main bronchus and the left main bronchus. Right main bronchus produces an obtuse angle. It is steady, shorter than the left, measuring about 2.2 centimeters, while the left side is 5 centimeters. And it is easily seen on the CT scan. The bronchi usually produces ring shadow on the chest radiograph. دكتور ما أدري قبل وبعد is okay يعني أقدمه okay تمام. Talking about the lower segments of the lung, the bronchi, the right main bronchus is divided with its arterial supply to form right upper lobe and right middle lobe are separated by the minor fissure. On the lateral chest radiograph, the right lower lobe is separated from the right upper lobe and middle lobe by the major fissure. Back to the segmental division of the lung, the right upper lobe is divided into apical, anterior, and posterior segments. The middle lobe is divided into medial and lateral lobes, segments, and the lower lobe is divided into a superior and 4 basal segments here. Anterior, lateral, and we have the posterior behind. Passing to the left side we have the left upper lobe and the left lower lobe on a PA radiograph. All fissures are seen more clearly on the lateral chest radiograph. The left upper lobe is equal to the right upper and middle lobe, and it is composed from the apico-posterior, anterior, superior lingular and inferior lingular segments. And the lower lobe consists from the superior segment and 3 basal segments, which are the anterior, posterior, and the lateral segments. Passing to the blood supply, the pulmonary artery. The pulmonary artery is divided into the right and left main pulmonary arteries. The left pulmonary artery arches over the left main bronchus and is responsible for the higher position of the left hilum, making the bronchi hypoarterial in position, while on the right side the artery goes inferior to the bronchi, makes its position epiarterial.
The bronchus is epiarterial?
Yes. Okay, so talking about the interstitium of the lung, the interstitium is composed from the central part called the axial interstitium, and it passes laterally to the periphery. In the periphery, we have the subpleural interstitium and the interlobular interstitium. Intralobular interstitium connects between the axial and the subpleural interstitium. Once there is edema in the axial interstitium, there will be cuffing in the posterior anterior radiograph, while edema or pathology in the subpleural interstitium or interlobular septa will appear as a curly B line. Passing to the posterior chest radiograph, soft tissues of the chest wall consists of skin, subcutaneous fat, and muscle. Both breast shadows should be evaluated routinely to detect evidence of prior mastectomy or distorting mass. For the bones, the thoracic spine, ribs and costal cartilages, clavicles and scapulae are routinely visible on the frontal chest radiographs. 12 pairs of symmetric ribs should be seen. Cervical ribs are identified in approximately 2% of individuals and may be associated with symptoms of thoracic outlet syndrome, means compression on the brachial plexus. The lung-lung interface, as seen on frontal radiographs, relates directly to the space available in 3 regions viewed on the lateral film: the retrosternal space, the retrotracheal triangle, and the retrocardiac space. The retrosternal airspace reflects contact of the anterosuperior aspect of the upper lobes. On frontal radiograph, the anterior junction line is seen as a thin vertical line that overlies the thoracic spine. It disappears after sternotomy or when there is abundant anterior mediastinal fat. A second potential lung-lung interface is seen on the lateral chest radiograph as retrotracheal triangle, a radiolucent region representing contact of the posterior superior portions of the upper lobe. The third potential lung-lung interface occurs in the retrocardiac space. If that space is large, the esophageal recesses of the right lower lobe can be seen. The pre-aortic recess can abut the pre-aortic recess of the left lower lobe to produce an inferior posterior junction line. This is the retrosternal space, and this is the retrotracheal triangle, which is bordered by the posterior surface of the trachea, the anterior surface of the spine, and the aortic arch inferiorly. And we have the retrocardiac space. Talking about the anterior junction line is seen as a thin line on the CT and through the spine. About the lung mediastinal interface, the superior vena cava should be seen as a straight line or concave. Azygous arch measurement should be made through the midpoint of the azygous arch perpendicular to the right main bronchus. In general, a diameter of more than 10 millimeter. A diameter of more than 10 millimeter on a PA radiograph should raise the possibility of mass, adenopathy, or dilatation of the azygous vein. The latter, or the dilatation, may be seen with right heart failure, obstruction of venous return to the heart, or a congenital venous anomaly such as azygous continuation of the inferior vena cava. An increase in the diameter of the azygous vein from prior comparable radiograph is more important than the actual measurement. These are the normal mediastinal lung mediastinal interfaces. I will go one by one through it. The zygoesophageal recess interface is a vertically oriented interface overlying the thoracic spine. Convexity of the superior third of the interface should suggest subcarinal lymph node enlargement or a mass. Convexity of the middle third of this recess is usually a result of the confluence of the right pulmonary veins or the right border of the left atrium. Left atrial dilatation will enlarge and laterally displace the interface, producing a double density interface composed of the right lateral border of both the right and left atria. Convexity of the inferior third is most commonly due to sliding hiatus hernia. The paraspinal interface is a straight vertical interface extending the length of the right hemithorax. A focal convexity of this interface suggests spinal or paraspinal disease. The right heart projects just to the right of the lateral margin of the thoracic spine on a normal posterior anterior radiograph. The inferior vena cava interface is best visualized on the lateral radiograph. Passing to the left mediastinum, the subclavian artery. It's unusual for the left upper lobe to interface with the left lateral wall of the trachea to form the left paratracheal strip, because the subclavian artery and adjacent fat usually intervenes. Aortic knob. Down we have the left superior intercostal vein, seen in 5% of individuals, superolateral to the aortic arch, which it's called a nipple, which it is called the aortic nipple, which measures less than 5 millimeter. Enlargement caused by elevation of right atrial pressure. Aortopulmonary window. This interface is usually straight or concave toward the lung. The latter appearance is seen with a tortuous aorta, emphysema, or congenital absence of the left pericardium, so the concave appearance is abnormal. A convex lateral interface should suggest mass or lymph node enlargement in the aortopulmonary window. I have a problem with should, maybe. Should be straight. Main pulmonary artery, then the pre-aortic recess interface, seen in a small percentage of normal individual as a reflection of the left lower lobe with the esophagus anterior to the descending aorta. Left paraspinal interface seen in majority of individuals. Lateral displacement indicates a disease. Left arterial appendage, straightening or convexity. Atrial appendage. Straightening or convexity of this interface used to be seen commonly in rheumatic mitral valve disease, but may be seen in patients with left atrial enlargement of any cause. Now, left ventricle comprises most of the left heart border, and we have the epicardial fat pad. Regarding the lungs, the opacity of the lung may be increased by processes that render the interstitium or air spaces opaque, or decreased by any process associated with diminished blood flow to the lung or destruction of parenchymal structures. Diaphragm on frontal radiograph exposed to deep inspiration. The apex of the right hemidiaphragm typically lies at the level of the 6th anterior rib. Abdomen, portion of liver, spleen, and gastric fundus are routinely visualized on most frontal chest radiograph, and it will help for estimation of the situs. Passing to lateral chest radiograph, soft tissues are usually seen because the air will outline the axillary folds till it reaches the arm. Above the bone, the anterior margins of the scapulae projects as oblique straight edges overlying the superior and posterior aspects of the thorax, often over the retrotracheal triangle. The anterior and posterior cortical margins of the thoracic vertebrae should be aligned, forming a gradual kyphosis. Lung interfaces. The retrotracheal or Rader's triangle is bordered by the posterior border of the trachea, the anterior border of the spine, and the top of the aortic arch. Masses and airspace disease near the apices, retrotracheal masses, for example, aberrant subclavian artery or posterior thyroid goiter, or esophageal masses may produce an abnormal opacity in this region. So we have the retrosternal, retrotracheal triangle, and retrocardiac, 3 spaces to look for in lateral chest radiograph. The appearance of the retrosternal space depends upon the shape of the sternum and the amount of the anterior mediastinal fat, which is called the strip. Sternal fracture, infection, tumor, or prior sternotomy can distort or thicken this strip. Inferiorly, the left lung may be excluded from contacting the anteromedial chest wall by a round or triangular opacity, which represents the aortic apex and adjacent extrapleural flap. Cardiac apex. And it is noticed as the lingular incisura. A mass arising within the anterior mediastinum may not be visible on a PA view, but will usually encroach on this retrosternal clear space. The anterior pericardium can be identified in 20% of subjects as a thin line. Nodularity or thickness more than 2 mm suggests disease or effusion. Posterior aspect of the inferior vena cava is visible in the majority of individuals. Absence in pediatric population occurs with cardiac abnormality.
So the posterior aspect of the IVC on the lateral chest X-ray is very important to look for. If it is not there, there is a big problem.
Let us pass to this one. This is the posterior aspect of the inferior vena cava.
You should see it always.
Sorry. Hemidiaphragms appears as parallel domes structures on lateral radiograph. The posterior portion lies at a more inferior level than the anterior portion, creating a deep posterior costophrenic sulcus and a shallow anterior sulcus. Methods for distinguishing right from left. The right hemidiaphragm can be traced till the sternum, while the left the lower end of the hemidiaphragm is not seen. So the left side cannot be traced because the anterior portion has been silhouetted by the heart. So the one which is not completed, cannot be traced, is the left. This is the first method for distinguishing right from left. The right anterior and posterior costophrenic sulci should project beyond the corresponding left-sided sulci as a result of X-ray beam divergence. Identification of the right and left costophrenic sulci allows identification of the corresponding hemidiaphragms. The presence of air in the stomach or splenic flexure projecting above the hemidiaphragm and below another identifies the more cephalad structure as the left hemidiaphragm. The right and left major fissures are distinguishable. The left is more vertically oriented than the right. Following a major fissure to its point of contact with the diaphragm will allow identification of that hemidiaphragm. Passing to the anatomy of the mediastinum. I hope I can cover nicely. The mediastinum is a narrow, vertically oriented structure. Lies between the medial parietal pleural layers of the lung. It contains the cardiovascular, tracheobronchial, fat, lymph node, esophagus, and nerves. The mediastinum is generally divided into the superior and inferior mediastinum, and the inferior mediastinum is divided into anterior, middle, and posterior mediastinum. But for our radiology, makes it all together, anterior, middle, and inferior. These are the structures. Anterior.
There is no inferior and superior division.
Superior.
And there is
يعني
classification of division by person.
And for making it easy. These are the normal structures present in the mediastinum. Regarding the anterior mediastinum, this is the thoracic outlet. The thymus, Dr. Afu, the thymus is not seen in this session. The thymus is not seen in this session. It is the thoracic outlet. Here we can see the trachea, the thyroid, esophagus, common carotid, internal jugular, and the muscles. Talking about the anterior mediastinum, the thymus is located anteriorly, which is seen as a triangular bilobulated structure. This structure usually involves fatty involution. So by the age of 35 years, it's mostly composed of fat with some glandular tissue. Mostly the left side lobe is larger than the right, and by this age it should have flat or concave edges. This, we are in the anterior mediastinum. Posteriorly, we have the right and left brachiocephalic veins. The right brachiocephalic vein exhibits a vertical course. So in transection it appears round, while the left one, as it crosses, it will have a tubular or ovoid shape. This is the aortic arch level. At the aortic arch level, you can see we are now in the middle mediastinum. This is the trachea. This is the pretracheal space. The pretracheal space it has the aortic arch superiorly and the trachea inferiorly. Let me just here, please only notice the pretracheal space. The pretracheal space contains the fat, lymph node, and retroaortic pericardial recesses, which is used for mediastinotomy. In this session, I can talk more, in this level, we can talk more about the aortopulmonary window. This is the carina, ascending aorta, descending aorta, esophagus, superior vena cava, and these are the lymph nodes. Coming down, we have the main and left pulmonary artery levels. This is the main and left pulmonary artery level. Ascending aorta, descending aorta, truncus anterior branch of the right pulmonary artery. In this level, we are at the right pulmonary artery and azygoesophageal recess level. This is the main pulmonary artery, right pulmonary artery. This is the azygoesophageal recess. Is it too late? Okay, talking about the hilum. The hilum represents junction of the lungs with the mediastinum. I will pass quick. Okay. It is mainly composed of the right and left pulmonary arteries. Right and left pulmonary arteries, the superior pulmonary vein, lobar bronchi, bronchopulmonary lymph nodes, and fat. 90% of normal individuals, the left hilum is higher than the right, and we have talked about that the left main pulmonary artery arches over the main bronchus, and this is the cause. If the right hilum is higher than the left, this suggests volume loss of the right upper lobe or the left lower lobe. Okay, on lateral, or this is a sagittal view of the left hilum. This is the left main bronchus. Continuously with it is the left lower lobe bronchus. This is the aortopulmonary window between the aortic arch and pulmonary artery. This is the descending pulmonary artery. This is the right hilum. This is the right main bronchus, which is seen less commonly than the left main bronchus. If it is visualized for the first time, not visualized from the previous one, this indicates a disease is present, a mass or lymph node enlargement. The most important is the middle bronchus intermedius. This is the bronchus intermedius. Thank you. Bronchus intermedius, it should be no more than 2 millimeter. This is the middle bronchus. This is the lower lobe bronchus. This is the superior vena cava, and this is the right pulmonary artery. Few points about the pleural anatomy. The pleura is serosal membrane that envelopes the lung and lines the costal surface, diaphragm, and mediastinum. It's composed of two layers, the visceral and the parietal pleura, that joins at the hilum. The pleural surface is potential space between the two pleural layers and normally contains a small amount of fluid, less than 5 millimeters, that reduces friction during breathing. The normal costal, diaphragmatic, and mediastinal pleura is not visible on plain radiographs or CT. High-resolution CT, it can be detected on high-resolution CT. A 1 to 2 millimeter strip may be seen lining the intercostal spaces between the adjacent ribs.
Can you slide through the remaining slide just very fast?
It's finished, only one. Chest wall anatomy. CT provides detailed anatomic information about the normal chest wall and axilla. And lastly, anatomy of the diaphragm. The diaphragm is composed of striated muscle and large central tendons separating the thoracic and abdominal cavities. Diaphragm has 3 normal opening and 2 potential gaps. The aortic hiatus at the level of T12. The esophageal hiatus T10, inferior vena cava T8, Morgagni foramina at the anterior medial diaphragm. Bogdalik is at the posterior lateral diaphragm. CT image will allow for proper identification of these structures. And thank you for listening.
Thank you. Very nice, very good, very beautiful.
Thank you so much.
Very good effort in presenting everything. It's not an easy thing to present. I know.